Joining us for this week's Your Health segment is Dr. Joshua Abzug, professor of orthopedics and pediatrics at the University of Maryland School of Medicine, chief of pediatric orthopedics at the University of Maryland Medical Center, and deputy surgeon-in-chief at the University of Maryland Children's Hospital. Doctor, thank you for being with us.
Thanks for having me, Jeff.
At the beginning of the program, we mentioned a study indicating that a lot of childhood injuries are being treated inappropriately. We're talking about fractures. What did the study find?
So let's just back up 1 second and clarify what fractures are. So fractures equals broken bones. So quite often people come in and say, is my child's arm broken or fractured? And just so we're all on the same page, they are the same thing.
Right.
And what we looked at in this study was what happened when the splints got put on in either an emergency room or an urgent care center. Was the splint appropriate? Was the position the correct way? Did they miss a diagnosis? And was there any injury caused by the splint that was placed? And the conclusion of our study, we found that 93%, almost every splint that's put on, or 9 out of 10 splints that are put on in either an emergency room or an urgent care center for a child fracture, is placed suboptimally or incorrectly, depending on how you want to look at it.
Are there degrees of that? Were some of them placed in a way that would really cause some harm and some of them just maybe not perfect?
Yeah, so the vast majority were not perfect, quote unquote, but we did have a subset that did cause some complications. So that was our secondary finding. About 15 to 20% of the splints will actually lead to some sort of complications. Those complications consist of increased swelling. They can actually cause wounds on a child. So what will happen is at the edge of a splint, let's say, for example, the splint stopped right at the end of my wrist here, beneath my thumb. The end of that splint or edge of that splint will actually dig into the child's skin. And a young child may not tell you what's going on, especially if they have a broken bone. They may just think this is normal pain. But over time, that splint will actually cause a wound. And there's a study that showed that 6 to 10 children actually wound up needing free flaps or muscle or skin taken from somewhere else in the body to cover a wound created from a splint.
Wow. So in a fracture, the splint isn't the ultimate treatment, right? I mean, am I right in thinking it's a temporary measure before somebody like you or an MD can place a cast of some sort?
Yeah, typically most fractures are treated in a cast. The splint is placed in these urgent care emergency room settings, and the goal of the splint is a fewfold. One is to stabilize the fracture. What actually hurts the most is when the bones can move back and forth. So the purpose of the splint is to stabilize the fracture, and then secondarily it will decrease pain and decrease swelling. Ideally, a child seen within a day, 2 days, by the orthopedic surgeon where definitive care can be placed. However, lots of things pop up in life. Car may break down, may have trouble getting an appointment. In the winter that we just had, maybe a lot of snow, and your appointment may get pushed back. And sometimes these splints that were meant to be on for a day or two wind up being on for a week or two. And this is what really the problems that can occur.
So is the takeaway here for a parent, grandparent who's watching and a child is injured, and say it's a weekend and the urgent care center is the only place you're going to see somebody, is the takeaway that you pretty quickly need to then get the follow-up appointment?
So I think it's always best to be seen as soon as possible by the person who's going to provide the definitive care for the injury. However, some complications can occur very quickly. So there's a condition known as compartment syndrome. All of our muscles are grouped inside an outer tissue layer, what's called fascia. An analogy is to think of like a hot dog with that outer coating. Well, if swelling occurs enough and there's no room for that muscle to get bigger, ultimately what will happen is that muscle will die. Also, those nerves inside that compartment can die. And that can lead to permanent deficits. And that can happen right away. If a splint is placed too tightly, within a few hours, this compartment syndrome can develop, and a child can lose complete function in an upper or lower extremity.
Wow. So what's the alternative, since there aren't a lot of orthopedic surgeons with Sunday afternoon hours?
Sure. So I think it's great to go and have the child placed and seen in an urgent care emergency room setting. That's what they're there for. And they're there ideally to stabilize any acute injury and recognize anything that's going to be suboptimal in nature. I think there's a couple of key takeaway points. If your child's continuing to complain of pain after the splint is on, something's wrong. The child should be feeling better and better with time. They should be on their pain medicine, and it should be controlling their pain. If they're not being adequately controlled with their pain, and you're seeing increasing swelling, especially, for example, in the hand or the feet, beyond where the splint ends, you probably need to go back to the emergency room or urgent care center if you're on a Sunday. If it's during the week, you call the orthopedic surgeon and get in as soon as possible within a few hours. You don't want to just let that child continue to be in pain unnecessarily.
So is that an argument for maybe if there's a choice between the local ER and the urgent care center, and you're thinking the ER may take a bit longer, maybe the level of care might be higher?
So I think there's pros and cons of both situations. I think there's more resources in most of our emergency rooms with the hospital attached. But I think timing is a factor. In an urgent care center, they typically can get you in and out much faster than in an emergency room setting.
Where do the injuries typically occur? What sort of, in the pediatric setting, what bones are being broken and how's it happen?
So one of the most common fractures is finger fractures and then followed by wrist fractures. Super common injuries. Most commonly they occur from sports participation. That's one of our most common injuries. And then there's a few injuries, a couple of rules I have for my children. So
I've heard of the no trampoline rule. Is that where we're going?
No trampoline is a good one.
Strictly enforced.
And no monkey bars. That's another good one. So monkey bars are great with appropriate supervision. The problem we see, especially in the fall or springtime, we have children that weren't quite old enough to do the monkey bars last year, and now they're kind of old enough to do them. And they get up there and they start climbing, but maybe they're not quite strong enough to keep their body up. When you think about the height of a monkey bar, you're up a good 6-8 feet. When that child falls onto an outstretched hand, very often fractures can occur.
How often do you see a trampoline-related injury?
At least once a week, usually more than that.
And is there a way, I mean, you see them in backyards all over the place, sometimes in settings that don't look terribly safe, and sometimes you see them with like a net around it. What do you recommend, aside from the no trampoline rule?
So I think so that's my personal rule. I don't know trampoline companies would like that, but that's my personal rule for my family. But I think a net is a great thing. It does prevent major injuries from occurring from a child falling off of a trampoline, for example. Another big rule is not to have the springs exposed, if possible, because when a child jumps up, they can land on the springs. I think the most important rule really is one person should be on a trampoline at a time. The most common time we see an injury is when there's more than one person on a trampoline. So as someone's coming down, another person's bouncing up, and they misplaced their step because the trampoline mat is now lower than it should have been, and that's when the injuries can occur.
Everything we were talking about with splints and kids, does it apply to adults as well, do you think?
So I think it's totally true in adults as well. We have seen it, but because of my practice, I don't see as many adults, and we didn't study it in adults. But I think the same principles hold true for adults as well.
Lastly, I've seen instances where you're not sure if it's a break or a sprain. And in that case, I guess you're still going through the same network of care.
So this is where children's bones are actually different than adult bones. In adult bones, the ligaments are stronger than the bones. So when you roll your ankle, for example, you actually will tear a ligament more commonly in an adult. However, in a child, the ligaments are much stronger, and the weakest part of the child's musculoskeletal system is actually their growth plate. So children will sustain growth plate fractures much more commonly than a sprain. Our general rule as we teach our residents and medical students is children don't sprain their ankles, they break their ankles. And that's true throughout the rest of the body as well.
Interesting. Dr. Joshua Abzug of the University of Maryland, thanks for your time.
Thanks, Jeff. Thanks for having me.
We do appreciate it.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.